All right, you guys. So we are jumping into another little mini unit here. We're going to look at pulmonary embolisms and pulmonary hypertension. So this is another little mini unit. There's not a whole lot of slides to this, only about 30 slides, but there is some really good nuggets of information when it comes to looking at pulmonary emboli and pulmonary hypertension. So when we start with looking at pulmonary embolisms or pulmonary emboli, we must understand that there is a classical presentation that we will talk about, and this right here with the cyanotic line right at the nipple line going up is a clinical, like, dead giveaway for pulmonary embolism. But the thing is, we don't always catch it if they're small. This would be a severe or a major pulmonary embolism. But let me get started before I get too far ahead of myself. When we look at kind of introducing or coming into pulmonary embolisms, the embolus must originate from one large thrombus or occur as a shower of smaller thrombi and may or may not interfere with the right ventricle's ability to perfuse the lungs. So what we're looking at is this could be a massive singular emboli, or this could be a kind of a shotgun approach where you have a bunch of little emboli that could or could not impact that right ventricle. When a large embolus detaches and it starts to pass through the right side of the heart, it'll ultimately get stuck in the pulmonary artery, one of the two pulmonary arteries, or it can navigate itself down into the pulmonary arterioles. When we look at a saddle embolus, often this is emergent, if not fatal, due to significant blocking of pulmonary blood returning to the left ventricle that is trying to pump blood out to systemic circulation. So these are a diagnosis or a condition that is no fun to play with. As a practitioner, I've seen maybe a dozen or so of these, and they are just no fun to navigate. When we look at kind of breaking down definitions, a thrombus is a clot that forms and remains in the vein. So a blood clot that is in the vein. An embolus is a dislodged blood clot traveling to another part of the body. So what we're looking for, or what we're finding, is that thrombus that dislodges and is starting to navigate. When we start talking about pulmonary infarction, this is when the pulmonary embolus is significant to disrupt pulmonary artery blood flow. And then a saddle embolus is the lodging in the bifurcation of the pulmonary artery. So you can see here, here's the right ventricle. Coming out of the right ventricle, you have your pulmonary arteries, your pulmonary trunk, your pulmonary arteries that bifurcate into the right and the left lung. That saddle PE sits right there and can obstruct blood flow to the left and the right lung. So definitely something with the saddle PE that we want to be aware of, and we want to be looking to identify these early so that we can try to treat these as quickly as possible. So when we have a pulmonary infarction, this is a much more severe look at a pulmonary embolism. Like I said, it can be one large thrombus, many small emboli, or it can be a saddle. And when we have that pulmonary infarction, we're going to have some pathophysiological changes. You're going to see some alveolar atelectasis, consolidation. It could even lead to tissue necrosis and even bronchial constriction. So we're going to see some airway closure with this as well. So that happens as a result of an inflammatory response secondary to, there's a release of serotonin and histamine and different prostaglandins that we get from our platelets that come from hypocapnia and hypoxemia that can lead to this bronchoconstriction. So when it comes to the changes inside the body, there's a number of different changes that actually take place. So looking at our pathophysiology a little bit closer, there's a blockage of the pulmonary vascular system that leads to pulmonary hypertension. This would be an increase in pulmonary vascular resistance. So if I look at an increase in pulmonary vascular resistance, my right heart has to work harder. That right heart working harder can lead to failure. Remember, Fick's law tells us that the further we stretch, the further we're going to snap back. But if I do that stretch too far, too much, it's going to lead to a floppy heart. And that can actually happen on the right side as well. And that happens secondary to this pulmonary hypertension. And all we're talking about is an airway, not an airway, but a vessel, that pulmonary artery, that now has an obstruction in it, which decreases the radius of the pulmonary artery. When we decrease the radius of a vessel, what happens to pressure? Pressure goes up. What happens to flow? Flow goes down, right? Poiseuille's law. So from Poiseuille's law and from this blockage, we see that it can lead to pulmonary hypertension. Prolonged pulmonary hypertension can lead to right heart failure. We see that it can lead to alveolar atelectasis. We talked about the bronchospasms, pulmonary infarction, and alveolar consolidation. So we see that with the pulmonary hypertension, we see that the increase in the pulmonary vascular resistance will actually increase the hydrostatic pressure as well. When we increase the hydrostatic pressure, remember, that's the pressure that tries to keep that's the pressure that pushes on the walls, that tries to push the fluid out of the vessels. And the oncotic pressure is what tries to keep everything in. We have this pulmonary hypertension, your hydrostatic pressure actually increases to be a value greater than the oncotic pressure. And the normal hydrostatic pressure is 15 millimeters of mercury. The normal oncotic pressure is 25 millimeters of mercury. So when we see the hydrostatic become greater than the oncotic, you're going to get fluid that seeps out of the pulmonary arteries or the pulmonary capillaries, and then you start to get fluid, particularly red blood cells that cross the AC membrane and into the alveolar spaces, the interstitium as well. So this is what we call, or this would be a form of cardiogenic pulmonary edema. When we see this, this will elicit an irritant response, making the patient want to cough. When they want to cough, well, that cough comes from that fluid that is in the alveoli now, and that those alveoli are filling up with fluid. That fluid is going to be blood tinged because it's the red blood cells that are the leading charge to that fluid. When we look at pulmonary embolisms, or pulmonary emboli, the signs that a patient is having a pulmonary embolism are so vague. They're so vague, and you can't really see what's going on. Patient's going to have some shortness of breath. Patient's going to have tachycardia. Patient's going to be eliciting or showing symptoms and signs and symptoms that could cross into many other conditions. And 25% of the time, the sudden death is the first symptom that we see, especially when it comes to large PEs. When we look at massive PEs, these are the #1 cause of sudden and unexpected deaths for all age groups. So when we have that kind of sudden, I want you guys to kind of circle, highlight, underline sudden death. I want you to be thinking about PE or sudden cardiovascular collapse, right? It doesn't necessarily have to be death. When we look at these are often undiagnosed and untreated, so we don't always get to see what's going on with the pulmonary embolism until the patient is coding. Due to the subtlety and the misleading clinical manifestations, a lot of times PEs are not considered when it comes to, hey, is this a condition or a reason that the patient is breathing the way that they are? It ultimately takes about 10,000 individuals per year, and the males are more at risk than females are. And usually about 70 to 80% of the cases, a PE will not be considered at all. So that when we talk about oftentimes not considered until autopsy, we're talking about 70 to 80% of the time that we do not even think or consider pulmonary embolism before the patient has succumbed to this condition. We're going to talk about this here in just one second. So when we look at the etiology the pulmonary embolism comes from typically a deep vein thrombosis. So usually these are seen in the lower body, typically the legs or the pelvic veins, or even in the inferior vena cava. So we see the DVT in these areas that break loose, that move into the lungs, or that navigate from the right atrium to the right ventricle into the pulmonary trunk or the pulmonary artery. That leads to the stark visuals that we see with pulmonary emboli. When we look at causes, it could be a fatty structure, it can be an air emboli, it can be amniotic fluid, bone marrow, or tumor fragments. Well, you ask, how does air get into the vein that then travels to the heart? Well, you can get air in the vasculature from removing a central venous catheter or an internal jugular catheter. And this can be done with an IJ, subclavian. It can be done with a PICC line. Any IV, any catheter that is indwelling in the vasculature, that can lead to a pulmonary embolism. Same thing with an arterial line. An arterial line can do that same thing as well. So when we do this, we see that there's a structure that migrates through the venous system into the right atrium to the right ventricle, ultimately lodging into the pulmonary arteries or the arterioles. All right, you guys, so we're going to now talk about how a clot forms. So when we look at the way that a clot forms, it's through this phenomenon, through what's called Virchow's triad. And I'm going to upload a link that has more information on this, but it's typically from 3 different things. And this is venous stasis, hypercoagulability, venous stasis, hypercoagulability, and endothelial cell injury. So when we look at these 3 things, when we talk about venous stasis, this is the slowing or the stagnation of blood flow through the veins. And this happens because there's a very low pressure system on the venous side. The arterial side is very highly pressurized. And so the result of that is the blood is not moving as quickly as it would on the arterial side. Hypercoagulability is an increased tendency of blood to form clots. It just means that it's got an increased ability to form clots. And then injury to the endothelial cells, this is really the lining of the vessel. And this can come from a penetrating trauma, it can come from a blast or a crush injury, it can come from multiple IV sticks. Just anything that will impact or injure the endothelial cells, which is a lining in the vessels. Those are the 3 main factors that have to come to life in order for a clot to form. When we look at risk factors, there are 5 kind of categories of risk factors. We have venous stasis, we have hypercoagulability disorders or hypercoagulation disorders, surgical procedures, trauma, and others. So when we break this down and we look at venous stasis, we're talking about inactivity or patients that have prolonged bed rest. And when we look at this is somebody that they have a potential to get a pulmonary embolism from laying in the bed when it comes to being mechanically ventilated, right? We already talked about the risk that's associated with pneumonia, but now we have additional risk factors when it comes to patients that remain in the bed or are immobilized for prolonged periods of time. It could be something from prolonged sitting. So when you go on a long trip in a car or an airplane or even on a train, when you're in that sitting position, you're slowing blood flow down in the lower extremity, so it can cause an increased risk factor there. Congestive heart failure, patients that have varicose veins or thrombophlebitis, those are all different causes or increased risks that are associated with pulmonary embolism. When we look at surgeries, we're going to jump across the street here. When we look at surgeries, we're talking about hip surgery, we're talking about pelvic surgery, we're talking about knee surgery, and even some of the OB and gynecological procedures can increase the risk for pulmonary embolism. When we look at trauma, any bone fractures, whether this is the pelvis or long bone fractures in the lower extremities, that is going to increase the risk of a PE. It can even happen from extensive injury to soft tissue. This could be post-op or even postpartum states. You have extensive hip or abdominal operations. That's all going to lead to the potential for a PE. When we look at hypercoagulation disorder, these are oral contraceptives. So birth control. When we look at birth control, there's an increased usage of estrogen, and with that estrogen, it increases the risks for PE. Polycythemia. We've seen polycythemia before with our COPD patients. They produce more red blood cells because they need more buckets to carry the oxygen to the cells, tissues, and organs. So now your COPD population has an increased risk for pulmonary embolism. And then patients with multiple myeloma, which is a form of cancer. And then when we look at others, we're talking about patients that are obese, patients that have a pacemaker or indwelling catheter or venous catheter, pregnancy or during childbirth, supplemental estrogen, like with our oral contraceptives that we talked about before, smoking, burns, and even a family history. So when there's a family history for a condition, most likely that has a potential to pass down.